Hi everyone, and welcome to our module on ovarian neoplasia. Ovarian neoplasia can be classified by the ovarian cell type of origin of the cancer or tumor. So for example, there are tumors that derive from the connective tissue of the ovary, and these are called stromal tumors. Other tumors derive from germ cells in the ovary, they're called germ cell tumors. And then finally, many tumors derive from the epithelial cells that line the ovary, and these are called epithelial cell tumors. Let's start by talking about an ovarian teratoma, which is the most common overall germ cell tumor of the ovary. Teratomas contain cells from all three germ layers. So the three germ layers are the ectoderm, the endoderm, and the mesoderm. And you can find cells from each of these layers in a teratoma. For example, from the ectoderm, you can find skin cells and hair follicles. From the endoderm, you can find tissue that resembles the lung or the GI tract. And from the mesoderm, you can find muscle or cartilage. Many teratomas are benign. Those are also called dermoid cysts. This is a picture of what one looks like on the slide here. You can see all the different tissue elements like hair and bone. And then there is also a malignant form of a teratoma. This is called an immature teratoma. So let's talk about the benign form because that's more common. It's called a dermoid cyst, as I said on the last slide. It's also sometimes called a benign cystic teratoma. The word dermoid means skin-like, and it gets its name because it contains skin elements like hair and squamous cells. They also often contain a sebaceous oily material that you can find in sebaceous glands of the skin. And then besides the skin elements, the walls are often calcified and they contain tooth-like material. Many times these are asymptomatic and they're detected on routine physical exam. And you should know, especially for your boards, that up to 20% of cases are bilateral, so when you identify a dermoid cyst in one ovary, you have to evaluate the other one as well. And usually these can be diagnosed based on ultrasound. There are characteristic features, especially related to the bones and the calcium in the teeth. And if you identify these, you can usually know with a reasonable degree of certainty that a woman who has an ovarian mass has a dermoid cyst. Now, even though dermoid cysts are benign, they often lead to a number of clinical problems. First of all, they have a high fat content, and this makes them very slippery and mobile. And so they often lead to a problem called ovarian torsion. We'll talk about this later in this video, but this involves the ovary becoming twisted around its ligaments, and this can lead to ischemia and necrosis of the ovary. They can also potentially rupture, and this can lead to peritonitis. And then there's a very small risk of malignant transformation. Some of the elements can become malignant. For example, the skin elements can turn into a skin malignancy. In many cases, squamous cell carcinoma arises within a dermoid cyst from the skin elements of the cyst. So because of the risk of all these problems, when a dermoid cyst is identified by pelvic ultrasound, even though it's usually a benign mass, it's usually removed surgically so that you can avoid complications. Ovarian tumors can arise from the stromal cells of the ovary. Usually these are benign, but the thing you want to know about stromal cell tumors is that sometimes they produce hormones, and this can lead to some unique clinical presentations. Stromal cell tumors of the granulosa cells can produce estrogens. So if these develop in a girl, this can lead to precocious puberty. And so in the differential for precocious puberty in girls is the possibility that the girl may have an ovarian mass that's a stromal cell tumor producing estrogens. After puberty, the estrogens can lead to endometrial hyperplasia or endometrial carcinoma and also abnormal uterine bleeding. So it's rare, but in women who have these problems, sometimes they have a tumor in their ovaries that's producing estrogens. Stromal cell tumors can also sometimes make androgens. These are called Sertoli Leydig cell tumors. So androgens in a woman from an ovarian tumor are going to lead to hirsutism, which is hair growth like what's shown on the slide here. Androgens also lead to acne, and they can suppress menstruation, leading to oligomenorrhea or amenorrhea. Androgens can also cause atrophy of the breasts. Now usually when you see these findings described in a woman, you are going to think of polycystic ovarian syndrome because that's much more common than Sertoli Leydig cell tumors. But in PCOS, ultrasound of the pelvis will show multiple cysts in both ovaries. That's why it's called polycystic ovarian syndrome. If the ultrasound shows a single mass in one ovary, then you have to consider that that woman may have androgen excess from a Sertoli Leydig cell tumor. Another type of ovarian tumor is an ovarian fibroma. This is a benign tumor of fibroblasts. It's a solid white tumor like what's shown in the picture here that grows in the ovary. Usually these are unilateral and they have no hormone activity. They commonly occur in postmenopausal women, and they will present as a pelvic or adnexal mass. So in a postmenopausal woman with a pelvic or adnexal mass, the first thing you're going to think about is an ovarian epithelial cell tumor, which we'll talk about in a minute. But sometimes after surgical removal of the ovary and the mass, you find out that the woman actually has a fibroma. And there are two classic clinical associations with ovarian fibroma. The first is the development of ascites, which is common in women who have this tumor, and the second is the development of MEG syndrome. So ascites and MEG syndrome occur in about 40% of cases of ovarian fibroma. MEG syndrome is a triad of an ovarian fibroma plus ascites plus a pleural effusion. The etiology of this is unclear. It's probably related to capillary leak that's caused by some tumor factor that is released from the tumor. We do know that when you remove the tumor, that resolves the ascites and effusion. So in a woman who's postmenopausal with a unilateral pelvic mass who develops ascites and pleural effusions, one of the things you should think about is that she could have MEG syndrome and that her mass may be an ovarian fibroma. Okay, so moving on, next let's talk about epithelial cell tumors of the ovary, which are the most common form of ovarian cancer. These tumors derive from the ovarian epithelial cell lining. This is the lining of cells that surrounds the ovary. And these forms of cancer easily spread directly into the peritoneum, so unfortunately there's often advanced spread of the tumor at the time of diagnosis. The classic presentation is an adnexal mass, and this is one of the major things we worry about when a woman has an adnexal mass. And besides a mass that you can palpate on exam, they may cause vague abdominal symptoms either from localized growth of the tumor or from spread. These are symptoms like bloating, early satiety, and pelvic or abdominal pain. And unfortunately, because these symptoms are relatively nonspecific, often the diagnosis of ovarian epithelial cell tumor is delayed and the tumor is advanced at diagnosis. And in general, this is a disorder of older women. The average age at diagnosis is 63 years old. There are a number of subtypes of ovarian epithelial cell tumors. The subtype is determined by microscopic examination of the removed ovary after surgery. The most common subtype is the serous subtype. It gets its name because it secretes water or serum. There's also a mucinous subtype which secretes mucus, and there's also an endometrioid subtype. This type gets its name because its appearance is similar to endometrium, and the endometrioid subtype, although rare, is famous for having a good prognosis. It's much more sensitive to chemotherapy than other subtypes. The different subtypes of epithelial cell tumors can occur as a benign precursor lesion or as a malignant tumor. The only way to tell them apart is to remove the ovary and examine it under the microscope. But when you do this, some of these tumors will be the benign form based on their histology. So the benign form of the serous subtype is a serous cystadenoma. The benign form of the mucinous subtype is a mucinous cystadenoma. Other times when you examine the tumor under the microscope, it has malignant histology. So for example, the malignant serous form is called serous cystadenocarcinoma, and the malignant mucinous form is called mucinous cystadenocarcinoma. And so when a woman has an ovarian mass and it's surgically removed and the pathology shows that it's a benign tumor, you have to consider removing the other ovary. That's because there's a possibility that malignant transformation will occur in the remaining ovary if it does not undergo surgical excision. Ovarian epithelial cell cancers can lead to diffuse spread in the peritoneum, and this can cause a condition known as pseudomyxoma peritonei. This is also called mucinous ascites because in this condition a gelatinous material called mucin accumulates in the abdomen and pelvis, and this can lead to ascites. And because this material is gelatinous and sticky, sometimes a bowel obstruction can occur. And so basically, pseudomyxoma peritonei means diffuse spread to the peritoneum, and you can see this in other forms of cancer besides ovarian cancer. The classic cancer to cause pseudomyxoma peritonei is cancer of the appendix, which is very rare, but it can also be seen in ovarian epithelial cell cancers as well. Let's talk about some of the risk factors for epithelial cell tumors. One way to remember a number of these risk factors is to appreciate that the more a woman ovulates, the more risk she has of epithelial cell cancer. Ovulation disrupts the epithelial cell layer of the ovaries and it has to regenerate, and that raises the risk of developing ovarian cancer over a woman's lifetime. So women who are older have had more ovulation, women who begin menarche early or have late menopause will ovulate more, and women who have never been pregnant ovulate more than women who have had children. The risk is lower in women who have had pregnancy, the risk is lower in women who have breastfed, and the risk is also lower in women who have taken oral contraceptive pills. All of these things suppress ovulation. Some other risk factors are shown on this slide. A family history of epithelial cell cancer is a risk factor. And then for reasons that are poorly understood, infertility due to any cause also raises the risk of epithelial cell tumors. In polycystic ovarian syndrome, women have multiple cysts within their ovary, and you can just imagine how this disrupts the epithelial cell lining to have all these cysts, and that raises the risk of epithelial cell cancer. And then women who have endometriosis also have a higher risk of epithelial cell cancer Tubal ligation, you should know, is protective. It lowers the risk of this cancer. This is probably due to some fallopian tube factors that lead to cancer, and so once the tubes have been ligated, those factors cannot affect the ovary, leading to cancer. In videos on breast cancer, I talk about the BRCA1 and BRCA2 genes, which code for DNA repair proteins. They're associated with an increased risk of breast cancer, that's why they're called BRCA genes, but you should know that they're also associated with an increased risk of ovarian cancer. So women who have one of these gene mutations have a higher risk of ovarian cancer. In videos in the GI section, I talk about HNPCC, which is the hereditary non-polyposis colorectal cancer syndrome, also called the Lynch syndrome. Patients with this condition have a germline mutation in DNA mismatch repair genes, and this leads to a higher risk of colon cancer. But you should know that patients with HNPCC also have a higher risk of other cancers. One of them is endometrial cancer of the uterus. This is the most common non-colon malignancy in patients with HNPCC. But one of the other cancers is ovarian cancer. Specifically, the serous subtype of ovarian epithelial cell cancers occurs more frequently in patients with HNPCC. CA125 is cancer antigen 125, and this is a biomarker for epithelial ovarian tumors. Unfortunately, measuring the blood level of CA125 has a very poor performance for screening, so you can't use this test to identify women with early evidence of ovarian epithelial cell cancer. CA125 is, however, useful when you're evaluating a woman who has an adnexal mass. I talk about adnexal masses in another video, but when a woman has a mass in the adnexa and her CA125 level is elevated, that raises the concern for ovarian cancer. Any value in a woman with an adnexal mass over 35 is abnormal, and a value over 200 is highly concerning for malignancy. The other place where CA125 is useful is for monitoring the response to treatment in women who have ovarian cancer. After a woman is treated, the level should fall, and you can do serial measurements for follow-up. If the level starts to rise, that raises concern that the cancer may have recurred. The management of epithelial cancers is complex, and it depends on the stage of the cancer, but I'll give you some general principles. First of all, the surgery that's usually performed for ovarian epithelial cell cancer is a total hysterectomy with a salpingo-oophorectomy. This means removal of the uterus and the fallopian tubes and both ovaries. Basically, because this tumor is so aggressive, you can't just remove the tumor or just remove the ovary, you have to take out the entire reproductive system. When the tumor has spread, what's often done is known as cytoreductive surgery, also called tumor debulking. This refers to removing the tumor from the peritoneal cavity and other structures to which it has spread. And the idea here is that studies have shown that chemotherapy is more effective if there's less tumor mass. So if you can surgically reduce the tumor mass, it makes it more likely that the chemotherapy will work. After these types of surgeries, adjuvant chemotherapy is administered. Usually it's a platinum-based chemotherapy. This means that either carboplatin or cisplatin is used as part of chemotherapy. Often one of these drugs is given together with the drug paclitaxel. We'll finish this video by talking about ovarian torsion. This refers to rotation of the ovary around the suspensory ligaments. And when this happens, the ovary can become ischemic and undergo necrosis. This usually happens suddenly, and so it presents with the acute onset of pelvic pain with an adnexal mass on examination. Classically, women have waves of nausea and vomiting, and this can mimic appendicitis. The reason I'm talking about it in this video is because the major risk factor is an ovarian mass, especially if the mass is greater than 5 centimeters. When there's a mass like this in the ovary, it makes it much easier for ovarian torsion to occur. This can also happen to women who have ovulation induction as part of a fertility treatment. Ovulation induction can lead to large cysts, and those make it more likely that ovarian torsion will occur. In a woman with suspected ovarian torsion, the best test is a pelvic ultrasound. This can identify an ovarian mass, and it can also show limited Doppler flow, meaning limited blood flow to the ovary, and so these findings confirm the diagnosis of ovarian torsion. Sometimes a CT scan is done first because the woman has acute onset abdominal pain and there's concern for appendicitis. The findings of ovarian torsion by CT scan are nonspecific, like enlargement and edema of the ovary. When you get a CT scan and you have those findings, it's followed up with a pelvic ultrasound to confirm ovarian torsion. And then the treatment is surgery. Torsion is a surgical emergency. There are 2 procedures that can be performed. One is a detorsion, which is basically untwisting the ovary. The other is a oophorectomy, which is removal of the ovary. Which procedure is done depends on the viability of the affected ovary. And that concludes our module on ovarian neoplasia.